Hello.
Hi.
Hi, Matt. How's it going?
Going.
Hi, Dr. Leff. Thanks for joining us.
Megan, how are you?
Good. How are you?
Good, good. How's my video?
You look good.
Looks good.
Oh, I like those glasses.
Thanks. Dad, would you like a lift-off background?
Can you do it from there?
No, but it's easy to do if I send you the file.
Yeah, okay, we have 8 minutes.
Yeah. All right.
Can you both see the Liftoff PGH holding screen?
Yeah, are you able to see my, I'm trying to share my PowerPoint. Do you see that?
You did share it, but I unshared it. So you're good. Whatever you did to do that worked.
Okay. So I'm looking at my email.
Megan, is that file? I think I have it, right? From you? The background?
Yes. Mara, I think Rebecca's in the waiting room, the attendees panel.
Great. Hi, everyone.
Hey,
Hi
Rebecca.
there.
Can you hear me okay?
You're perfect.
Good. Should I try sharing my screen?
Yep. Why don't we try that real quick?
Another person is sharing, so.
Oh, right. So Megan has to stop sharing. Let's see. Hang on one sec. Okay, Rebecca, you want to try?
How's that?
Perfect.
Good?
Yep.
Okay, can you hear me okay?
Great.
Great. All right. Stop share. All right.
So we're actually not seeing what's being shared. We'd have to be in the meeting. Is that it?
You can't see, you couldn't see that, Dad?
No, maybe I need to open more windows.
Or go to your view, top
I
right.
took it down. Let me put it back up.
Show manage participants. Show chat.
What are you seeing?
I'm seeing my PowerPoint, and then I'm seeing a screen with the 4 people on it.
Go to the very top, it says view.
Yeah.
The top of the Zoom screen.
Yeah.
Try a different view. Side-by-side gallery.
I've got manage participants. That's good. I can see who's in there.
No, no, no. In the black screen, there's a little thing that says view.
Black screen view.
Like where the faces are.
Okay.
Is there a little thing that says view with little squares?
I don't think I have that.
All right, well, you'll just have to wing it.
Okay, as long as you can see it and I can see it.
Yes. All right, well, as people join, we will, they can hear us, so we'll be quiet and then I'll start us off right at 2, okay?
Sounds good.
Okay.
Are we trying the background?
No, we're not. You're
okay,
good.
Okay, I'm gonna keep studying. Okay.
We're just going to give it another couple minutes, maybe a minute, and we'll get started. Okay, good afternoon, and thank you for joining us for this afternoon's session. My name is Mara Leff, and I am the Director of Innovation at the Jewish Healthcare Foundation and the Director of the Liftoff Pittsburgh Conference. Thank you to everyone who have been participating with us thus far. We are on week 2 of the conference, getting ready to finish up on Friday in preparation for our big live broadcast on the 15th. So please do mark your calendars for that. We have some amazing speakers. And we also have some amazing speakers with us here today. So our session today is called Demystifying Buzzwords in Healthcare. I think this talk came out of a lot of conversations between myself and my Liftoff team about the fact that no matter where you go, there are certain words that seem to be very hot right now in healthcare and health IT. But what do they really mean? And we're hoping to get to the bottom of that a bit today, to hear from 2 experts that certainly know a lot about these topics. So today we're going to jump right into that conversation. A couple housekeeping things. Please do ask questions throughout in the chat. We will hear from both presenters, and then we will circle back and do questions at the end. But keep the questions coming, and we'll get back to those. And please feel free to ask anything. No question is a dumb question. So if you need clarification or more information on something technical that you hear, please do not hesitate to ask. So the first speaker I'd like to bring up, full disclosure, we are related, is my father, Dr. Louis Leff. He is the medical director of e-record at Shadyside Hospital at UPMC. He's an internist by trade and is a lifelong Pittsburgher. He also has a company that he has been spearheading for many years called EBM Calc, or Evidence-Based Medicine Calc, and is an expert on what he calls calculated medicine, which he will tell you a little bit more about today. So with that, I will bring you on. Dad, the floor is yours.
Thank you so much, Mara. And thanks to your organization, Jewish Healthcare Foundation, for inviting me to speak at this great conference. I've been doing some clinical informatics stuff around the country and around the world for many, many years. But in Pittsburgh, I'm mostly known as Mara's dad. So Mara, congratulations, wonderful conference. Thank you so much. So I'm here to talk about FHIR, F-H-I-R. It's spelled funny, but it sounds like fire. And when you talk about FHIR, all puns are expected and basically encouraged and required. Everything about FHIR is on fire. I love this pup that's a firehouse Dalmatian dog. And
Dad, you're gonna have to share your screen, sorry.
How's that?
Perfect.
I love this pup. It's a firehouse Dalmatian dog. I got it at a giant HIMSS conference, and I really do miss going to in-person conferences. I think this is the second best thing what we're doing here. But you could get such wonderful merch like this. And I got this at the HL7 booth, HL7 International. It's a company that promotes health standards and data standards. But as I said, all FHIR puns are basically required. FHIR, let's talk about what FHIR is. Basically, it's 4 letters. We'll talk about the H first. There we go. The H stands for healthcare. And healthcare and computers have been gradually improving over the years. And I wanted to give you just a brief review of what's happening, at least here in Pittsburgh. In the 1980s, I was a resident. Personal computers were arriving but had minimal use in day-to-day healthcare. Eventually, laboratory systems incorporated computers so you could get your laboratory values ordered or returned through computers. Through the 1990s, early 2000s, we started doing more documentation, getting doctors and nurses to type more and keeping stuff in medical databases. Eventually, we started doing more patient management, direct order entry, and this started to take hold in the early 2000s through 2010. Many electronic health record companies began flourishing at that time. By 2009, the federal government strongly encouraged doctors and hospitals to use computers so strongly they basically incented doctors' offices to buy the equipment and lease the services and pay their electronic health record fees. The federal government actually paid more money than you needed to do that. And so you could make even a small profit by adopting computers in your office. And hospitals the same to do that. And the dollars for hospital use were huge. Still, these healthcare electronic records developed independently. So giant companies now like Cerner and Epic are proprietary database systems, and they basically keep data in silos, and these silos are not connected. And they are still not well connected, but it is improving these days. But over the many years, everyone expected to be able to go from one EHR to another and that it would easily understand data in another EHR, but that was not true at all for many, many years. Companies like Cerner, Epic, Allscripts, Athena, they have no direct way of talking to each other. Now, currently, this is changing, and we're at an inflection point in interoperability. And that's the I in FHIR, FHIR. The I stands for interoperability, a way of connecting disparate or proprietary systems. And there's tremendous demand for interoperability. It's the demand of common sense. It's just the right thing to do. Patients demand this. They want their data to be available when they go from one provider to another, one hospital to another, or when patients want to see the data themselves. They want to be able to get it on their devices. And now the government is demanding interoperability. At first, the Meaningful Use Program, which paid doctors and hospitals to begin using computer systems, has now evolved and changed its name. And this snow clone is literally true. The Meaningful Use Program has changed its name to Promoting Interoperability. So here's the full acronym, FHIR. F stands for fast, and it doesn't mean that it works faster. It's not a particularly fast database system. It's an average speed database system. The fast is how fast you can implement it. The data structures and the programming methods involved with FHIR are basic and easy to understand, and interesting applications can be developed very, very rapidly. It's fast. And the resources, FHIR is fast healthcare interoperable resources. Resources are ways of putting all of your health information into bundles. The patient resource, that has all the information about you, your address, your phone numbers, your doctor's name. The observation resource, this is where all your laboratory values live. The medication statement resource, this is where all your medicine lists live and such, and allergy and immunization resources. And these are all standardized terms and resources. So what is FHIR and where did it come from? FHIR was invented by a fellow in Australia, Graham Grieve, a program director or programmer who thought that healthcare needed something better. In about 2011, he introduced the concept of FHIR, and it picked up steam immediately. But this is this classic Gartner Group wisdom graph. So the initial excitement shows that the visibility of FHIR goes up really fast in the early 2010s. But then you come to the peak of inflated expectations, and then people wonder what you're doing, go down to this trough. And even Graham Grieve around this time, he redefined FHIR. He said, FHIR sometimes means far harder in real life. But gradually, as a community effort, the FHIR standard, how the data is represented and how the resources are standardized, has just improved tremendously. And so we go through the slope of enlightenment, and now by 2019, FHIR is a real buzzword and is starting to do real productivity. The US government insisting on interoperability for many years didn't insist on a particular way to do this, but they do hint very strongly that FHIR is the way. So here in a paper about what FHIR is by the ONC, the Office of the National Coordinator of Health Information Technology, they claim that FHIR has this strong focus on fast, easy development, that they like FHIR because it's free. It's an open standard system. You don't have to pay for it. You don't have to license it. And FHIR is being picked up everywhere. So giant companies like Apple, Microsoft, Google, and then the big electronic health record companies are all adopting it, creating their FHIR interfaces to their proprietary databases. So they all can speak the same language. It's a common language to electronic health records. And the system itself has a strong foundation in various web standards that we've been living with ever since the birth of the web. Extensible markup languages, JSON, HTTP. We'll talk a little bit about these. So FHIR has many inner buzzwords. RESTful, you'll hear that the interfaces of FHIR are RESTful. This is actually just the way websites work. It's how you represent your state, the representational state transfer. It's those characters you see after the website name in the top of your browser. It maintains state through a RESTful interface. JSON, this is this wonderful data structure that programmers love. Stands for JavaScript Object Notation, and programmers use this because they can represent almost anything in well-structured, human-readable object notations that they use to send requests to servers, to electronic health records, and then data is received in JSON structures, which is very easy to parse. And so this is another thing that makes application development so fast. FHIR uses codable concepts, code systems, and codes. And so standard code systems, you've probably heard of ICD-10, maybe you've heard of LOINC and RxNorm. These are standardized ways of looking at medical terminology through codes. And this also speeds the development of interoperability. Smart connections, as smart as the technology developed at Boston Children's Hospital, that enables you to make secure connections and reusable secure connections for, I believe it stands for substitutable medical app, something or another. But it's the essential but very quick action that begins when you connect your FHIR app to your electronic health record. This smart, secure connection that is very reliable. Let's look at some code systems. ICD-10, International Classification of Diseases. US was probably the last country on the planet to adopt it, but we have enjoyed it. It seemed at first complex, over 70,000 different codes, but it's always evolving. So with COVID, we're getting new COVID codes like U07.1. It has all kinds of codes, including weird codes. If you get sucked into a jet engine, that's a V97.33. And if you survive, you get to come back to your doctor a second time. There's a code for that too. And of course, we have to avoid during liftoff. There's actually codes for spacecraft collision injuries if you happen to get to your doctor after one of those. That's a V9543. LOINC, this is, to me, one of the biggest parts of inner FHIR, because so many things are classified with simple numeric codes, laboratory values, score systems, height, weight, vital signs. They all have LOINC codes, like your blood sugar, your A1C. And yes, the LOINC organization, it's part of Regan Street Institute in Indiana, founded by Clem McDonald, a very famous clinical informaticist. They adopted the pig as their logo because LOINC rhymes with oink. Charles Jaffe, he's the longstanding CEO at HL7, Health Level 7 International. And he is on the road and talks about FHIR all the time now. He is really excited by this and gives away his slides. And this is one of his slides, and I like it. He says that FHIR is both the technology and the agreement on the meaning of the data. And that's how you standardize data. Graham Grieve, in one of his papers on Health 2.0, he claims that FHIR is a critical enabler as a community solution. But it's not a complete solution because it's the technology that makes it work. But what I've learned in many years with clinical informatics, it's mostly the technology is often 1/4 of the effort, and the rest is the community, getting people to use it correctly, governing how you use technology. So I wanted to start with a new buzzword, and Mara mentioned I'm involved with calculated medicine, and this is my day job. I helping take care of patients at UPMC and working with the computers at UPMC. At night, I work on evidence-based medicine calculators in the field of calculated medicine, use of algorithms, equations, criteria sets, decision trees in clinical decision support, helping decide what's going on with patients. Brief history. There's Virginia Apgar, a very famous anesthesiologist, was involved with childbirth and was present for tens of thousands of deliveries and developed her Apgar score. Everyone who's had a baby has heard of the Apgar score. This was perfected in 1952, long before we used computers to figure out score systems. And it's based on the strength and regularity of the heart rate, the lung maturity, skin color, reflexes, etc. And each of these values has a point value. And somehow, before the days of computer regression analysis, she realized that these point values, no matter what combination you took them in, added up the same. And if your total was 7 or more, your baby was okay. And less than 7, you were in trouble. And less than 3, your baby was probably not even going to live. And this has stood the test of time. So somehow she knew that these were independent risk factors of various degrees. So an amazing example of calculated medicine. Here's Dr. Starsley, he just passed away a couple of years ago, very famous Pittsburgh surgeon. He virtually invented and perfected liver transplant surgery in the 1980s, and then the volume grew so much in the 1990s. We had to figure out how to figure out who was next to get a transplant. And so this is where the MELD score came, the model for end-stage liver disease. And it's a complex equation. Even in 2016, it keeps evolving to involve a new lab component. So this is our EBM calc system, and I want to show you a little bit more of it. We were founded back in 1998, so we've been around for quite a while. We're a mature product. We're used all over the world. We're in many other great resources. We're embedded in UpToDate, Hippocrates, various Walter Kluwer products like Lexicon. And for a long time, embedded in the Cerner electronic health record, our static product. It contains more than 730 clinical decision tools, including decision trees, clinical criteria sets, medical equations. Here's that MELD score. So this is the old style. This is our traditional calculator where the provider would have to find out the patient's creatinine level, bilirubin, INR, serum sodium, and whether on dialysis, punch them in and get the result. And then maybe copy that back or just talk to the patient about their score system. In the last 2 to 3 years, though, we finally entered FHIR, and we realized that we could pre-populate most of our calculators with data directly from electronic health records, and this would save clinicians valuable time, increase accuracy of data input, and also offer the ability to look at the results and perhaps automatically put them back into an electronic health record. So let's take a look inside of what this is, EBM Calc FHIR app. We'll look at a recent collection of new calculators added for the COVID-19 pandemic response, and this we have created and given away freely on our public site and created FHIR versions as part of our FHIR product. Here is EBM Calc, the FHIR app, working in a Cerner electronic health record model. Tim Peters is a fictitious patient. You can select calculators by category. We're choosing the COVID-19, and you see bunches of calculators that are important in critical care units. Calculators about lung disease, because a big part of COVID is the pneumonia and respiratory failure. Criticality predictors, mortality predictors, even predictors of how you might respond to ECMO, extracorporeal oxygenation, if you needed to go on one of those machines. Here's an example of a mortality risk estimator. It needs age, it needs to know whether you have coronary disease. SOFA score is another calculated medicine score, the sequential organ failure assessment score. Lymphocyte count, more is better in COVID. The more lymphocytes, the better you do D-dimer is a marker of blood clotting. The higher that is, the worse it is for you and your COVID. On the left, so the calculator is pulled up, and the calculator then requests automatically the data it needs. The data it needs is compiled on the left side. You see the albumin, the bicarb, blood pressures, body mass, BUN, and what these were pulled for other calculators, and then lymphocyte counts, D-dimers will be down below. Those data are automatically put into the calculator, and the calculation is done, and it is a simple matter to copy this back either as a clipboard object, and we are soon going to be able to copy scores directly into the Cerner health record. Here's just another one. The SOFA score is very important in following COVID patients, sequential organ failure assessment. And I'll show you the MSOFA, the modified one, and this one is becoming more popular because you don't have to take the blood off the unit. You only need to do one blood test for this score system. Creatinine can be done with a point of care device, and the rest can be done clinically. The MSOFA score is very indicative of how your patient will do. You see the data collecting on the left, you see the score, you pan down and you will see the interpretation. So this score is pretty good with only a 4% predicted mortality. Many equations and criteria sets work like this. You know, more typical ones would be routinely used. Your risk of getting a heart attack, your risk of getting stroke. These are based on your age, based on your total cholesterol and your HDL and whether you have diabetes. All of this stuff is easily pulled by FHIR. So we have fully embraced FHIR, and I think FHIR is really happening right now. And I think we are finally there. So I hope this has given you some idea of what these buzzwords are and an appreciation of where we're going. So thank you so much again for this opportunity.
Well, thank you so much. That was great. And we're getting some questions in, but we'll hold them till the end. So now I am excited to bring up our next speaker. You can stop sharing your screen, and then Rebecca, you can take over. Okay. So Dr. Rebecca Jacobson is the Vice President of Analytics at UPMC Enterprises, and she is also the President of Astrata, which is a really fascinating company that she's going to be telling us about today. She's also a board member at the Jewish Healthcare Foundation and has been a supporter of Liftoff PGH since the very beginning, and we're very grateful for her partnership and excited to have you with us. So Rebecca, I turn it over to you.
Thank you. Thank you, Mara. Thank you to JHF. This is a really exciting conference. I'm so glad to be here. So glad to be talking with Lou. I see we have a lot in common, including having more than one job. I'm going to tell you a little bit about NLP, which is a buzzword, a commonly used buzzword nowadays. And what NLP stands for is natural language processing. And what that is really a family of methods that can be used. They're computational methods that can be used for very diverse tasks and also in very diverse applications, both medical, clinical applications and things that are just used in your normal everyday life. And I'm actually going to start with the normal everyday life first. What these technologies have in common is that they really are used for the processing of human language. So that could be voice, or it could be electronic text, it could be handwriting, and sometimes it's used actually for the production of human-like language. And they can also be used for many different tasks, such as having a conversation with a machine or finding information, for example, finding information on the internet. And then finally, they can be used in many different types of applications. For example, translating a document from English to German, or summarizing a series of Twitter tweets about my product. All of these methods and tasks, applications, they all really are built on natural language processing, many of them. And you're probably using NLP all the time, and perhaps without even knowing it. So some examples of applications: if you've used one of these conversational agents, you are using NLP. If you've used language translations, such as one of these, trying to figure out what is the word for, can you bring me my bill? That is an application, a very common application of natural language processing. And finally, something like summarization, where you are looking to take individual tweets or a Facebook post, something like that, and figure out, and this is actually sentiment analysis, you want to figure out, like, do people like this thing or do they not like this thing? That is an example of NLP too. Let me dig a little bit deeper to just say, just a little bit about kind of the methods that are used. Earlier today, I sent myself an email. I said, hey, thank you for chairing that meeting yesterday. It went great. And I was using a commonly used email application. And you can see that on my the receiver here, which was also me, I've got 3 responses that the machine will kind of, the email application will let me just use immediately. And one of them was "you're welcome," and one is "it was my pleasure," and it was fun. So, and the idea is that it's really basically reading my email, and you may all have experienced this with the various email applications that you are using. So, so these responses here kind of, even just for something this simple, are kind of interesting. I mean, the first one to sort of note is the "you're welcome" here. And I mean, my mother brought me up to say, if somebody says thank you, you say "you're welcome." And so you can imagine that it wouldn't take much smarts to figure out that if the email is titled "thank you," that one of the responses should be "you're welcome." It's a little harder to explain these other ones because clearly there's some indication here that there was some kind of an event, in this case, a meeting, and that the person who sent it thought it went really well. So these responses, these other 2, "it was fun," "it was my pleasure," really have more to do with the whole content that's in that message. And that takes a little bit more intelligence or smarts. And many of the applications that are used in natural language processing use machine learning methods, especially lately, deep learning methods, which are a kind of an advanced application of artificial neural networks. And then more recently, over the last 10 years or so, we've had a technology that is hugely advanced natural language processing. It's actually a very simple technology. It uses neural network, but not a deep learning neural network, a very shallow one that helps to represent the relationships between individual words so that you can tell when words are similar being used in the same way. There's a famous kind of saying in natural language processing that, a word can be understood by the company that it keeps. And so here, for example, you can see a short message, but the event here, you could probably think about the fact that there's an indication that there was an event by the fact that there was a mention of something happening yesterday. So the great thing about language is that language is just infinitely expressive. And you can think about, writing a letter or having a conversation, either in a spoken language or, for instance, in this case, in sign language. And the amount of information you can communicate when you do that is pretty remarkable. And it's much, much easier to communicate information doing one of these 2 things than the alternatives. For instance, if you were given kind of a Mad Lib for how to write a letter, you would have very limited kind of flexibility, ability to really express yourself. And the same thing if I gave you a bunch of magnets and I asked you to have a conversation, you would be limited to only being able to express certain things. And in many ways, that is something that is constantly going on in our world, because technology often wants to limit what we can say. And you can imagine, for example, we see this all the time in the EMRs that Lou was just talking about, because they are often built of a bunch of drop downs, radio buttons, and things where people have to select something. And often the kind of things that they want to say may not actually be reflected very well in that. The language of healthcare is also very, very expressive. We can say a lot, and we can say a lot whether we're, for instance, in this top case, talking to our provider, or in the bottom case, talking amongst providers, talking physician to physician or nurse to nurse, et cetera. And this example here on the right is an example of a very commonly used way to communicate between providers, and that is a clinical note. A clinical note is a written piece of documentation that is in this electronic medical record that Dr. Leff talked about, but it's a very special kind of piece of information because it's entirely free text. There is no structured information. There are no terminologies like loink, et cetera, written in here, just words. And the words themselves have very specific meaning, and they're put together in very specific ways. And they may not be very familiar to people who don't know too much about clinical medicine. So a word like salpingo-oophorectomy, for example, you probably don't use every day. And there are also a lot of acronyms, for example, like BID, which again, is not something that we'd typically use. It means twice a day. Well, this field of natural language processing in medicine is definitely now a recognized thing. And there's a recognition that there's a lot of value in bringing these methods that have been developed both within medical informatics, but also more generally in computer science used for other things, such as some of the things that I talked about previously. And UPMC has recognized and really invested in this field. And that's most apparent in the 4 companies that are portfolio companies now. Abridge, a company that deals with making it much more easy for patients to get information out of their appointments with their providers by giving them a summary of what happened. It's an app that you can actually download onto your phone. Health Fidelity, that is a company that works with health plans to understand the risk associated with specific patients and populations. Realize Intelligence, a company that uses NLP with providers. And now, most recently, Astrada, which is a company I'm going to tell you a little bit about. Before I do that, I'll say that these natural language applications, they can be used in a very wide range of tasks and applications in medicine. So they can be used, for example, to identify patients for clinical trials, to recommend services, like should a particular patient be seen by PT or OT. Often that's something that takes a lot of different information from fragmented places. The area that we're working in is really measuring healthcare quality. How do we find out are providers doing the right things, and how good is a particular provider at doing a particular thing? And for health plans, what's the quality of the health care that my members are getting across all of the providers that may be providing that health care? These are 2 really important questions because our society is really in the midst of a huge change, which has actually been going on for a number of years. Pretty much unimpeded by all kinds of changes, including changes in administrations, for example, and the federal government. And that change is one from fee-for-service medicine, where providers are incentivized to kind of do things like order tests and et cetera, to one in which the providers are really incentivized for taking, for the health, the long-term outcome of their populations. And that change requires data. So in order to get better, in order to learn what works and how do I improve and how do I get, for instance, the diabetics in my practice to have the optimized values for their blood sugar, in order to do that, I need data. And that data is used to drive this continuous improvement cycle where you identify problems, you plan, you execute, and then you review the data that you get back from them. And this kind of virtual cycle is really the foundation of improving the health of populations. It's really the foundation for this value-based care that is kind of what we are evolving towards. But it's actually very difficult for healthcare systems and providers and health plans to do this virtual cycle. And part of the reason for that, well, you heard it from Dr. Leff. Part of the problem is that there really isn't a lot of interoperability among systems, and healthcare is fragmented. Part of the problem is that language is very expressive, and it turns out that a lot of the information that we need to understand the outcomes, to understand whether the right thing is being done, is actually in text. And part of the problem is that the infrastructure that we have is mainly based on things like billing codes. So I can tell you that for the average health plan, the way that they know that their members are getting the care up to a particular standard, using some kind of measures, how many of a ratio, like how many of my patients had this, or the members in my health plan had some particular standard of care, the way they do that is really through billing. So it's that they find out that there was a claim submitted for something and they analyze that claim. And that's not a very good way, actually, to find out very much, and it's very delayed. So what we are doing at this new company called Estrada is using these natural language processing methods to figure out two main questions. Is the provider doing the right thing? And can we measure different providers using measures that are developed by national agencies like the National Center for Quality Assurance or CMS, for example, Center for Medicaid and Medicare Services? And the second question is, for a health plan, are my members getting the right care? So answering these questions using this natural language processing really is the essence of what we are starting to do. And we were fortunate to be selected. So the technology of NLP is really gaining recognition. It's really gaining traction. And we were fortunate to be selected by the National Center for Quality Assurance, which is the main measurement steward in the United States and regulator for health plans, to help them figure out how do we certify NLP systems. So I want to give you two quick examples before I wrap up of what does this really mean? How does it work? So let's start with, we saw Dr. Leff give examples of scores. And the score is very relevant to an individual. So it can kind of tell you where you are on some spectrum. For populations, the really interesting question is, what is the ratio? So the denominator might be everybody for whom something should happen, like some particular type of care should be given. And the numerator is how many times did they get the right thing? And so a simple measure that we could look at, for example, is in colonoscopy. So that's something that you have when you're over 50, and the idea is to inspect the colon using a scope, a flexible scope, and to do that to identify lesions that can turn into cancers. And the idea is actually to decrease the incidence of colon cancer. And so, so a very simple measure is the number of colonoscopies that are performed where one of these lesions is removed divided by the total number of colonoscopies. And this measure is called the adenoma detection rate. And it's very important because it turns out that there's very strong evidence that, that this measure is inversely associated with the risk of cancer in the future. And this is a measure of individual providers. So in other words, if I'm doing colonoscopies and I have an adenoma detection rate which is high, it means that I am really good at finding these lesions. So I do a good job in my colonoscopies for my patients, and I'm able to find a lot of these lesions, and so that ratio is going to be high, and it's an indication of my success as a colonoscopist. But it's very hard to measure because, again, this data is the data that you need to calculate it is typically in free text. So Estrada has been working with 18, actually the GI service, the gastroenterology service at UPMC, across 18 different facilities, and also with our Wolf Center, which is a healthcare quality center. And so our software is now deployed and is automatically processing data from tens of thousands of patients so that we can feed that data back in the form of these ratios to individual providers to tell them how they are doing so that they can get better. The second example is actually from the health plan, and this is one where we're really interested in intervening. So again, the measure itself, and the intervention is with women who had a recent fracture. So the measure itself is very simple. It's the number of women 65 to 85 who suffered a fracture and had the necessary additional imaging or therapy for osteoporosis. So older women are susceptible to this disease of the bones, osteoporosis, which leads to fractures. And it's a common cause for morbidity and mortality among older women. And it's very important to identify when a woman who has had a fracture and is not known to be an osteoporotic, to have this disease, in order for them to be screened and or treated for the disease, because there's a very strong evidence base, again, to suggest that women who are treated will have better outcomes. They will live longer and they'll have a better quality of life, actually. But again, very hard to use this wonderful measure that we have because healthcare is very fragmented. I might have a provider in one town, but when I have a break of my arm, that I go to a emergency room in another town that's closer to me, and that information doesn't make its way back, and nobody picks up the fact that I had a fracture and I need to be evaluated for osteoporosis. And that's particularly true that the health plans want to know who these patients are, but they have a hard time identifying them because typically they're relying on claims data. So yes, in 3 months, it might be that the claim for that fracture make its way to my health plan, my insurance company, and eventually they figure it out. But it could be so far after the fact that it doesn't even register to me. Oh yeah, I had a break in my arm a few months ago. I'm fine. I don't need this heel scan or this other testing to tell me if I have osteoporosis. Consequently, if you look across the country, the scores on this ratio across the whole country are actually quite poor because we're not intervening fast enough. So this is an area where Strata with UPMC Health Plan have been working to much more rapidly identify these members so that we can figure out there was a break, the break is relevant, they are not being treated and they've not had the appropriate imaging. These are the individuals that our health plan wants to reach out to help the providers to find this data so that we can intervene more rapidly and get them the treatment that they need. So in summary, natural language processing, or NLP, it's a family of advanced analytics measures that is starting to be used in real-world clinical settings. And then, of course, elsewhere in the real world where it's much more commonly used, I would say. Healthcare organizations are adopting these technologies for many purposes. And as a result of UPMC's investment in this space, Pittsburgh is really a hotbed of healthcare NLP, which is exciting. And as the newest company in this area, Strata is really looking forward to joining the Pittsburgh technology ecosystem. Thank you. And we're looking forward to your questions.
Thank you so much, Rebecca. And so now we have had a few questions come in. So we'll jump right in. It looks like this one is for you, Rebecca, from David Feingold. Strata seems to pivot on health literacy. Are you collaborating with anyone at Pitt Public Health or RAND?
So, so typically health literacy focuses on the consumers. So I want to make sure I'm understanding the question first. Let me answer the second part in case you want to put something into the chat about the question. We're not collaborating with anyone at RAND or Public Health. It's a great idea though. Mainly we are actually focused on these national measures, which are produced by CMS and by the National Center for Quality Assurance, NCQA. So that's primarily where we have been kind of focusing our kind of collaborative efforts.
Great, and we'll see if David, if you want to put anything else in, we'll circle back. This one is for you, Dr. Leff. Tushar says, are you able to plug in pathology test results for COVID? How granular is the inflammation?
Okay, thanks. Our score systems and calculators are taken directly from medical literature, and there actually are bunches of new predictive equations and calculated medicine tools being suggested in the literature. We jumped on this at bleeding edge. We captured some of these virtually days after they were published, and our system allows us to build calculators very quickly. Can I share my screen again?
Sure.
Okay. So, are you seeing anything?
Yeah.
So here is our public website, ebmcalc.com, and in it we have released freely a bunch of our COVID calculators, and say something like this. This one here is a newer one from May, and granular data such as age, various other laboratory values, whether you have comorbidities, whether you have an abnormal chest x-ray, whether you're coughing up blood or not. Each of these are fairly granular data that help predict the severity. As direct pathology results, nothing in COVID. We have a bunch of breast cancer calculators. Here's one, your risk of recurrence after a simple mastectomy. It's an old study, but the disease is not that much different. If you simply do a mastectomy, you can look at the grade of the tumor, whether the lymph nodes are negative or positive, whether there's lymphatic or vascular invasion, and the point values add up, and then the points are put into an interpretation table, which gives you a 15.8% chance of recurrence. So data like that is possible. One thing I wanted to mention about ABM Calc is that we don't create anything new. Our stuff all comes from peer-reviewed literature, and we represent the medical literature. We make the medical literature dynamic and interactive, but we do not do any kind of meta conflagrations or try to create new score systems. We're always open to new ones. And in fact, Rebecca, we have collected over 1.4 million articles to date that involve calculated medicine. The medical literature is burgeoning with this, and sometimes 300 to 500 new articles a day are published that involve score systems, algorithms. We capture these electronically from the National Library of Medicine PubMed base, and we are applying natural language processing to the abstracts to see if we can interpret them or find patterns, because no human can read 1.3 million abstracts. And so that's a very exciting new venture we're getting into.
That's great.
There you go. Another application.
Yep. Rebecca, what do you think? Tina asked, do you think that NLP data could lead to biased outcomes?
Great question. One thing I would say that we deal with all over medicine is that our determination of outcomes from data is almost inevitably biased in some way. And you see that in part because, the delivery of healthcare is biased. For instance, we see this in the difference, for example, between Medicaid and Medicare patients, because we're processing data on patients who are in those two programs and the patients who are in Medicaid programs, who are typically in lower socioeconomic status groups with a lot more difficulty and in obtaining healthcare, that we see many fewer events. And it could be that those events are less documented, but I think typically it's just that they're getting less healthcare. So yes, I think it's possible that any form of data analysis in clinical medicine is going to have biases. I would argue that actually NLP reduces the bias in general when you compare it to other things. And the reason is, if you're only using structured data, then you're only using data that comes from providers that have good EMR systems, that have got some degree of interoperability, that are advanced enough to be sharing their data, more real time with their health insurance companies, et cetera, et cetera. So in fact, I would say that using these other methods to kind of like reach out and get more data and to process more data actually probably reduces the bias that we see in some of these measures.
That's great. A question came in, and this is for both of you. What do you see as your biggest challenge towards adoption of both of these methodologies from both a clinical perspective? I know you talked about it a little bit, Dr. Leff, but also from a policy perspective, what are the biggest challenges?
You want to go first, Leo?
Biggest challenges. I see in one of the questions people ask, how do you verify the quality of what you do? How do you know it's good stuff? I can tell you, at least in my little company, we're little, and we are not world experts in anything, but except maybe in the creation of these calculators. And we rely on our partners, and we rely on our well-respected partners, like the UpToDate company that every resident in the world trusts for their medical education. We often get ideas for new algorithms, new calculators, new things to add to our product from the great experts, the real world experts. We only use data that's from well-accepted peer-reviewed articles. We were a little bit on the bleeding edge with the initial COVID stuff, but the world was in a panic, and that's what we did. We moved fast to try to meet the needs of the panic, but we've since slowed down. So I've got a queue of maybe 8 new COVID calculators, and we're going to do much slower this time.
I would say in some ways the same thing, actually, which is that in NLP, that validation really is how accurate is the NLP when you compare it to like the alternative, which is kind of like a human reading it basically. And that's the most important thing, that we need to be accurate. And so that's probably and to do that, you have to have some pretty sophisticated evaluation methodology. This is not something that you can kind of do in a fly-by-night kind of way. It really needs to be rigorous in order to prove that it's going to work. So that's one thing. And then the second thing that I think, and that's hard for people to do. It's just very hard for companies. It's hard for academics. It's just hard to do it, and it's expensive. The second thing, though, is that medicine, and particularly like the measurement of the quality of healthcare, is highly regulated, as I've kind of hinted at with some of these organizations. And so you really need them to be the ones that are driving things, much like the HITECH Act, you know, drove the adoption of EMRs in a way that probably nothing else would have worked. It's the same way with measuring quality in healthcare. I think that, you know, these regulators and the federal government have got to start making it an imperative that instead of collecting our data with billing, that we collect it with clinical data, that they need to make healthcare organizations, you know, more accountable for the reporting and for doing something with that healthcare data.
That's great. We had a question come in. Do you work with Cerner only or with other EMRs? And I think that actually could be for both of you. You know, Rebecca, which EMRs, you know, does it make a difference? Anything, any data?
Text.
Text.
Right, and when it comes to our algorithms and calculators, we use the FHIR standard, and the FHIR standard works almost the same in every EHR. It's not perfect. We're still not at that level of complete standardization. You know, we're especially tied to Cerner because we had our static calculators in their distribution to all customers, all Cerner customers for over 7 years. And it was Cerner who really pushed us to do FHIR because they were hearing from Cerner customers they wanted automatically populate the data, but the same app should work the same in Epic and Allscripts and Athena. We just have not made that push yet. You know, we were so ready to go. We were approved by Cerner a month before the giant HIMSS conference was going to happen in Florida. And wow, we were super excited. And that conference was canceled a week before we were going to travel down to Florida because of COVID. So, you know, a 70,000 person convention. So yeah, we're a little more Cerner centric, but we hope to be able to work in Epic, Athena, and Allscripts later.
Wait, maybe another question. Another question that I have, you know, so much of Liftoff is about Pittsburgh and how can we help companies thrive here and attract new companies to build their businesses here in the healthcare innovation and life sciences innovation space. And you two certainly are doing that. You know, sort of what can we do as a region to help better support founders and folks, you know, that are working to get companies off the ground? You know, we're very privileged here to have, you know, large academic medical centers and a pretty vibrant startup community, and obviously, you know, Carnegie Mellon and Pitt and other universities with lots of young talent. So, you know, what do you all need to help grow your companies here?
Great question. I mean, I think you hit on all the major things, Mara. I'll just focus.
Maybe I've been doing this too.
On the talent one, because, you know, that is the lifeblood of startups, is great talent. And I think that Pittsburgh has the potential to make such better use of the incredible talent that we are, you know, creating, that we're educating here at both Pitt and CMU and other universities and colleges around the city. But I don't feel like there's a degree of connection between those institutions and the startup ecosystem that you see in some other cities, frankly. So for me, that would be the number one thing.
Yeah, I have to agree. I mean, Now, Rebecca, you may remember I came to your office a year or two ago and asked you, what is NLP and can you teach me how to do it? And after about an hour, you were very kind, and I didn't have much idea. But I have found these geniuses at CMU, graduate students, who are really good at it, and what a resource. And similar students at Pitt. And we were surrounded by these young, bright people who are excited to do these new technologies. So that's I don't consider my company a startup. We've been around doing this for 20 years, but the FHIR product, that is a startup in our business, and NLP is certainly brand new to us. Yeah.
All right, well, I don't think we have any more questions. If it's all right with you both, can we distribute your contact information?
Absolutely. Please
Okay,
do. Yeah.
Wonderful. And we'll give everyone back 5 minutes to their afternoon. Thank you so much for being with us.
Thank you. It was so much fun. And thank you so much.
All
Really
right.
enjoyed the
Take
rest of
care,
the
everyone. Have a great day.
Bye.
Great session. Thank you.
Bye-bye.